I request Dr. Kumar Amruth to come and deliver his talk on innovations in glaucoma drug delivery. Is it the end of eye drops?
Good morning all. Thank you APOS.
Kumar, please stick to the time, no?
Sure.
Because the other people will come next session.
First of all, I want to thank APOS and AIOS for this opportunity. So I'll be talking on the innovations in glaucoma drug delivery. I think Madam has already covered few of the slides. So as we all know, glaucoma is the leading cause for irreversible blindness, and so the primary risk factor is the high intraocular pressure. So it is also the only risk factor that is modifiable. So the therapeutic approaches at present available are one are the topical hypotensive medications, laser therapy and the surgical therapy. So medical therapy is the first line of therapy. So it is simple, safe and also effective. Generally we start with a single medication, so as to reach the target pressure we keep on adding the medications. So topical therapy has got many limitations. So two main limitations, one is the non-compliance, other one is the effectiveness of the therapy. So there are different reasons for this non-compliance. So one could be the elderly age group, and the cost factor is one of the important limitation. Then forgetfulness of the eye drops, and the side effects, both the ocular and the systemic side effects of the topical therapy. And the other thing is the efficacy of this topical therapy. So once you install the eye drop, so less than 5% of the medication reaches the target tissue. So 90% gets into the systemic absorption. So there are many reasons for this lesser bioavailability of these topical medications. One, it could be due to very short contact period with the cornea, so rapid turnover and drainage through the nasolacrimal duct. So we can see only, say, the other thing is the size of the topical eye drop, so which is around 30 to 40 microliter, whereas the size of the conjunctival cul-de-sac is hardly 7 microliters. So more than 90% of the drug wastage is also much higher with the topical therapy. So the other issues with the topical therapy is, one is the ocular surface disease, and so there are different, so there is a need for ideal drug delivery because of the limitations that we have with the topical therapy. So what should be an ideal drug delivery? So it should deliver the drug at a constant rate. It should have a more contact period. The bioavailability of the drug should be on the higher side with minimal side effects. So there are different techniques. So there are, I have mentioned only a few, the inserts, contact lenses, punctal plugs, nanotherapy. So these are broadly classified into two, the extraocular devices and the intraocular devices. So we'll just go through only few of these implants. So one is the gel forming drops. So what this is, these are actually a liquid forms, but once they come in contact with the tear film, they convert into a gel-like structure, and they stay there in the cul-de-sac for over a period of month, and slowly the drug being eluted onto the ocular surface. Then we have the inserts. So these are devices which increases the contact time of the drug with the ocular surface, thereby increases the bioavailability. So some of these ocular inserts are already being discussed by Madam, say the pilocarpine inserts, OcuSert. Then we have the collagen shield, which is placed on the cornea, which is a small disc. Then you have the mini disc, which is placed under the upper eyelid. So all these ocular inserts stay there in and around the eye, slowly eluting the drug onto the ocular surface, increases the contact period of the drug to the ocular surface, and increases the bioavailability. These can last up to few weeks to months. Then the biomethoprost ocular insert, I think already discussed. So this is a ring shape placed in the fornix. So it stays there for few months and slowly eluting the drug. So then you have this TOD, the topical ophthalmic drug delivery. So it is like a contact lens made up of hydrogel placed under the upper conjunctival fornix, contact lenses. Then we have the punctal plugs, the ocular therapeutics. So these also, say the punctal plugs slowly elute the drug onto the tear film, and these can stay up to 3 to 6 months. Then you have some subconjunctival inserts are there. So these are very small, the size of a grain, and need to be implanted, but they need a procedure either in the OPD or in the theater. They needs to be implanted under the conjunctiva. Then you have this micro electromechanical system. So this works on the principle of electrolysis, and the rate of electrolysis will regulate the amount of the drug that is released onto the ocular surface. So this is the micro electromechanical pump system. So what are the issues with these extraocular implants? One, how well they will be tolerable, because these are placed in and around the eye, how well they will be tolerable. There are some side effects with these devices also, the hyperemia, the irritation, the foreign body. So again, we need to know how long these devices will deliver the drug at the right dose, the therapeutic concentration. They have to be maintained all throughout the time the implant is there. Then you have the intraocular, that is Durasta. It is the only FDA approved device at present available in the market. So it is placed into the anterior chamber but needs a injectable injector. So usually done in the theater. So then you have this Travoprost XR. This is also placed in the anterior chamber. It is a rod-shaped implant. And then iDose, so this is a titanium with a reservoir, needs to be anchored to the trabecular meshwork, so you need an invasive procedure, so it has to be done in the theater. So with these intraocular implants, they are definitely much more tolerable than the extraocular implants because they are placed inside the eye. So unlikely to fall out. They have much longer duration of action when compared to the extraocular implants. So it easily bypasses, say there is no problem with the barriers. So as it is placed inside the eye, surface side effects also less likely when compared to extraocular implants, but the only thing is it requires a minimally invasive procedure to implant. So the advantages definitely when compared to topical therapy, there is a reduced dose frequency, so less drug wastage, no need to install the drops daily, fewer side effects when compared to topical therapy, and better diurnal IOP control when you compare to the topical therapy. Topical therapy is like pulsatile. Once you put the drop, the peak action it will be there again, it comes to plateau. But here it is a better diurnal IOP control with these devices. And finally, it ensures the adherence and compliance with the glaucoma patients, and it can improve the quality of life of them. So to conclude, definitely topical therapy has got few limitations, the most important being the adherence and the efficacy of the therapy and the side effects with the topical therapy. So there is a clear need for some sustained release devices. So many of these devices that we have discussed are in the preclinical and clinical stages of development, and the data that we have today is mostly on the animal studies and few on the human trials also, but much larger trials has to be conducted before these devices are available for clinical use in glaucoma management. But when these devices comes into use, definitely it will improve the clinical management of glaucoma, and also it will improve the patient quality of life. Thank you.
Kumar, how often you are using in your clinical practice? In your clinical practice, how often you are using this?
No, sir, we are not using.
You have no experience.
Not using any of these devices.
Only theory.
Say, only at present, only one drug is available, which is FDA approved, is Durasta. All other are still not available. Only Durasta is the only one which is approvable, and it is some centers I think are doing. Other all are still in the different stages of development, clinical trials. Okay,
Thank you, Dr. Amruth.
Thank